Hi guys, it's Kathy. I hope you're doing well. Donald said he can't wait for the ever-changing story part 2, and he's right. We're not going to get to the end today. There's going to be a part 2. So, we I I'm like 58% sure we got this guy a couple months ago at an initial hearing, and it was domestic violence case, and he had the story, and well, now we get to see the hearing. We get to see the whole domestic violence hearing, and everybody's story just keeps changing. It's crazy. So try to keep up. Did she get hit by a mattress, or was all the blood from a popped pimple? I don't know. I just don't know. But today we're gonna see. There is one gory picture, and I have it all blurred out. So today we're gonna see a picture, and we're gonna talk to doctors who took care of her when she went into the emergency room, and tomorrow we're gonna see body cam of what she said when the police first arrived. Today we're gonna hear what she said when they got to the hospital. We're going to hear tomorrow from him. Well, we're going to hear what he said at first, and then it changed to something else. And we're going to hear him on the stand. And we are getting a verdict on this one. So, we are in Warren County, Ohio, I think. Pretty sure.
And please, you solemnly swear the testimony you're about to give in today's case to be the truth, the whole truth, and nothing but the truth, so help you God. Yes. Thank you. This is your microphone, so we need you. Please, you solemnly swear the testimony you're about to give in today's case to be the truth, the whole truth, and nothing but the truth, so help you God. Yes. Thank you. This is your microphone, so we need you to come forward for us. Okay.
30%.
Yes, Your Honor. Good morning, doctor. If you could state your name, spell your first and last name for the court reporter.
Yes, Natalie Kreitzer, Natalie Kreitzer.
And I think we talked a little bit about your background. You have some experience in neurocritical care.
Yes, sir.
And can you just explain for the court what neurocritical care is?
Yes, so I did a fellowship in that, and basically we take care of all of the patients downtown who have some type of neurocritical illness or injury. So common things are ischemic strokes, who've been treated, or like larger strokes, intracerebral hemorrhage, traumatic brain injury, ongoing seizures.
This is the ER doctor that treated her the day she went in.
Other like types of encephalopathy, subarachnoid hemorrhage, like ruptured aneurysms, for example, large spine surgeries. So we take care of them while they're in the intensive care unit.
So if you could, can you explain sort of the intake patient process for when a patient presents at the emergency department at your facilities?
Yes.
This is her. Right here. She's sitting over here today. That changes too. This is him. Right here. This is the prosecutor. And this is his attorney. I don't know if we ever find out who she is. Can't remember.
So at UC or Westchester, a patient checks in. They're usually seen first at like the registration desk. They're seen initially by a triage nurse who evaluates their complaint and we'll either send them back to an open bed if we have one available, or would get vital signs like blood pressure, pulse, that kind of thing, if we don't have an open bed yet, and they have to be like waiting for a period of time, for example.
Okay, and after that initial registration check-in from triage, what's the next process? What's the next step that a patient generally would go through?
So they would either wait in the waiting room if we don't have like an immediate bed available for them, or more commonly at Westchester, we do have a bed available. So they would come straight back, and then another nurse would do like their second triage, which would be like more extensive, asking like a series of required questions, getting initial blood work started, things like that.
And after that secondary nurse triage, if the decision's made to place a patient then at a room, is that generally when you get involved, when the physician gets involved, like after this sort of nursing triage, or how does that work?
Usually that's the case. Usually that's when we would see the patient. If we're in a state where we've got a lot of boarding, for example, like right now with influenza, it's pretty busy. We'll sometimes see patients like out in the lobby, or we'll see patients in a triage room if we don't have a room available, just to like get things started for them and everything. But in the most common, in the ideal circumstance, yes, that's when we would see them.
I just want to make sure that sort of we have a clear, like, that there is a process, sort of structured process for patients to do intake where medical information is gathered before you ever see them.
Correct.
And do you, in your position and the way that works, do you have access to the information that's gathered in that initial triage and that secondary triage?
Yes, so the nurse will chart things, and that's what I would be able to see in Epic.
So today we're here to talk about your care for a patient by the name of Ashley Klinker that occurred on July the 25th of 2024. Were you working at UC Westchester on that day?
Yes.
And you have before you what we previously marked and been referring to as States Exhibit Number 1. Those are, and have you had an opportunity to review those records in preparation for your testimony as well?
Yes.
And I just would, so we have those there to assist with your testimony, but just so we're clear, do you also have an independent recollection of your interactions with Ms. Klinker on that day?
I do.
Now, I want you to take a look.
I just bumped my microphone up. Is the sound better, or am I too loud? By the way, I might have got this whole video that we're going to play for 2 days just because her name is Mrs. Klinker.
At those the records there, are these this when you were talking about charting, is this sort of the compilation of charting that occurred through multiple medical professionals who interacted with the patient?
Yes, it looks like that's the case.
And are these records that are regularly kept in the course of treatment so that multiple medical professionals can refer to them?
Yes.
And if I could just refer you to the very front page of that, these records have been certified by University of Cincinnati by their records custodian on August the 21st of 2024.
Okay.
Okay. Let's talk about July the 25th. Do you have a specific shift you normally work, or?
No, it varies.
So do you recall what shift you were working on July the 25th?
I was working 2 p.m. to 10 p.m. that day.
All right. And were you working in the emergency department as you previously described?
Yes.
And do you recall how you first came into contact with the patient, Ashley Klinker?
I went into her room that she was placed into. That was the first time I met her, saw her.
Okay. And did you take over her care from those sort of triage nurses the way you previously described?
Yes.
And so do you recall, I can refer you to page 17 of States Exhibit 1, but do you recall what time it was that you first took over her care?
It was about 5 o'clock.
Okay.
Yeah, it looks like it was 5:13 p.m.
Okay.
based on this.
And at the time, before you go in to meet a patient in the room, do you review the information that was previously gathered by triage?
Yes,
And did you do that on this day?
I'm sure I did.
So what was the information that you had about Miss Klinker's medical condition and the circumstances of her injury at the time that you first encountered her?
I would have had what was written in the notes prior to me seeing her.
So do you recall what the nature of her medical condition, why she presented at the ER?
So the nurses had said she had initially said a mattress had fallen on her, but then had told one of them that she had been assaulted by her fiance.
Okay, and what was the medical complaint that she was reporting with?
A head injury, essentially.
Now, is this history that's been given by the patient, or the history that's recorded is that important for making medical decisions for you?
Like the history that the nurses obtain in triage?
Yes.
Yes.
And how do you use that information? What do you do with it?
So it depends if it can help you decide, like, based on mechanism of injury. In a trauma patient, for example, we have specific criteria that would automatically generate a trauma consult or a trauma alert, which would get our trauma surgeons down there. Knowing the mechanism of injury is important to know what types of injury pattern you might see, things like that. So.
Okay. Now, you said that you encountered Miss Klinker, and it looks like from the records that she was in.
I forgot I popped my microphone up again. Is my sound better? Hi, Replay Crew. Love you, love you.
Room C25.
Yes.
And you're familiar, obviously you work at UC Westchester. Are there different areas of the ED that have different letters?
There are, yes.
Okay. And what's the difference between, say, A pod and C pod, or are they just different?
There's no difference. We have A pod, B pod, C pod. Those are general rooms that a patient could be placed in. We also have an area called I pod, which is like more minor care type beds. And then we have 2 trauma bays.
Okay. Now, before you encountered Miss Klinker, was it your understanding that she had requested a private room or had requested to speak with you privately?
I don't remember.
Okay. All right, if you could just describe for the court what you observed of Miss Klinker when you first encountered her in room 25, C25.
Yeah, so my record and then what I remember seeing was that she was awake, she was alert, she was oriented, her vital signs were stable. I do remember that there was a lot of bruising around her right eye, and that was kind of how she looked when I met her.
I'm going to show you State's Exhibit number 2. We've had this previously identified by some other witnesses, but you take a look at that.
I have this blurred out and covered with like a sticker. So it's on the screen for quite a while.
Does State's Exhibit 2 accurately reflect what you recall of what you observed of the injury to her eye when you encountered her on July the 25th?
Yes.
Now, as a doctor, when you observe this type of injury, what are your sort of initial medical concerns about an injury of this type?
So with any type of trauma to a patient, we always kind of go very systematically, airway, breathing, circulation, and just kind of...
It looks like she popped a pimple, and that's what happened, right? And that's what he said when the police first arrived. She popped a pimple, and that's what caused this.
Check after that, top to bottom, any areas that are painful, any areas that may require imaging, and then kind of once the stability of the patient has been established, then honing in on what the specific injuries are. So an injury like this, I would worry about damage to the eye itself, damage to the facial bones, a possible head injury, possible cervical spine injury.
Now, you said that you did you do an examination of Miss Clinker, like not just her face, but the remainder
Yes.
of the body? And other than this obvious injury to her face at the time, did you observe any other contusions, bruises, bleeding?
I don't remember specifically, but if it's not in my record, then no, I would not have.
Looking at your record, I think there was charting related to diabetes injection sites on her stomach.
Okay.
But just if you could take a moment to review that.
Sure.
Certainly, if you had observed other bruising or injuries, would you have made notes of that in your chart?
Yes, I would have.
All right, so once, and as part of that initial examination, also having that discussion with the patient about their injury, right? Their
Yes.
subjective experience. And so did you have a conversation with Ms. Clinker on that day about what her injury was and how she was feeling and that sort of thing?
Yes, because I would just typically with every patient ask, are you having chest pain? Are you having abdominal pain? Does it hurt when you walk? Are you having pain in your hips? Just kind of going top to bottom to get a sense of, even if they don't have any outward signs of trauma, where they're hurting.
Okay. And did Ms. Clinker on that day, did she express that she was in pain?
I do remember she told me she had a headache.
Okay. And was she expressing that there was pain associated with the eye injury?
Yes.
And did she express, other than a complaint of a headache, head pain, and eye pain associated
Well, it's killing me.
with the eye injury, did she complain of any other areas of injury?
I've documented that she had some pain on the right side of her nose, but no, other than the eye, the right side of her nose, the headache, no.
So if she had complained of injuries to, say, her knees, her hips, elbows, wrists, things like that, you would have documented those in your chart?
Yes.
So if you could, given the nature of her complaint and the injury that you observed or your examination, just can you kind of walk through the court your decision-making in terms of her care from there?
Sure. So she, we will traditionally get, like I said, with any kind of accident, trauma, things like that, you always worry about airway, breathing, circulation. So most of the time we'll get a chest x-ray to look at the lungs. And then for her specifically, I would be worried about a head injury. So the way to look at that is a CAT scan of the head. Also worried about like facial bone fractures. So the way
I think she has 3 fractures in her skull, but I'm not sure. The doctor should tell us right here.
to evaluate for that is a CT maxillofacial, and that looks at all of the bones and the face, the sinuses, and then cervical spine imaging, just because if there are injuries to the head or to the face, then it's extremely common or can be common to have cervical spine injuries that are concomitant.
Now, Doctor, you had information from the triage nurses that Ms. Klinker had disclosed that she had been the victim of an assault. That's what had occurred to her. Did you have any conversation with her or ask her about this the mechanism of the injury?
I did, and she had told me that a mattress had fallen on her, but then I do remember having a further discussion with her about her injuries and saying that, like, this doesn't appear to look like a mattress fell on you. I'm worried for your safety.
And what was her response when you expressed that concern?
She was very tearful. I told her that I was specifically worried that if somebody, what she had told triage was that her fiance had done it, and that if this were to continue, that, ultimately the injury in the future it could be far worse than this, potentially even fatal. And I do remember she was very tearful, and she said that her boyfriend or fiance had been going through a lot of like stressful situation and was depressed, and there were things going on. So
Now, you said that you had concerns about her history of how this occurred. And is that based upon your training, your experience with trauma patients?
yes.
And so what was it about her explanation about this mattress fall that concerned you?
I mean, it just didn't really seem consistent with all of the eye fractures or the orbital wall fractures that she had sustained, the subarachnoid hemorrhage. It just, to me, it just didn't fit. It fit more with what she had told the triage nurses, that she'd been assaulted.
Okay, so just so that we're clear, she did not ever make a statement to you saying that her fiance had assaulted her, or did she ever make a statement like that to you?
Not that I remember, no.
Okay. Now, we talked a little bit about sort of the results of the CAT scan, so I want to make sure we have a timeline here.
Sure.
Was your conversation with her related to the mechanism of injury after you had got the results from radiology?
I think I talked with her about the mechanism of injury both before,
The picture comes down soon, I think. It's up there for a while, though.
like when I was seeing her initially, and then when I updated her about what the findings were.
Okay. I just want to go back sort of about after your initial examination with her. I know you said that you had concerns for facial fractures or cervical spine injuries, and so you were going to order a CAT scan.
Yes.
Did you order or prescribe, based upon her expressions of pain, did you order medications for her?
It does look like it. I don't remember from my own memory, but it does look like I had ordered some pain medications for her.
And what was prescribed to her?
If I remember from looking at the medical record, I'd given her oxycodone, but I would have to look specifically at the.
That's right. I think if we start on page 16, I think it is.
Sorry, it's just hard
I'm
to
sorry,
remember.
I think page 17 is where you took over her care. And I'm just
Yes,
gonna
it does
refer
look
you
like
to
I
the bottom
ordered.
of page 17, it looks like there were
Percocet.
orders placed at 1744.
Yes.
Do you see that?
Yes.
So it looks like, so the records reflect that at 1744, you ordered oxycodone for her. Your name's sort of on the side there, so I
Yes.
guess that's you. Okay. And so just for purposes of, court reporter's writing all this down. I think most people know what oxycodone is, but if you can explain for the court, what is oxycodone?
So it looks like I ordered oxycodone and acetaminophen, which is Percocet. So it's a combination of oxycodone, which is an opiate pain medication, and then acetaminophen is the generic name for Tylenol.
And so this dosage, looks like this dosage amount 5-325, I'm assuming that's milligrams.
Yes.
Can you, are there different dosage levels that you can prescribe?
Yes.
And what about this, why did you decide on the 5-325 milligrams?
It's the lowest dose. It's the most common dose that we would use, and you can always give somebody more medication, but you can't take away. So you sort of start with, lower dose and see how, kind of reassess somebody and how they feel.
So I'm just going to refer you then to the top of page 18.
Sure.
If the chart indicates that there was a pain assessment done at 1749, were you present when that pain assessment was done?
Just so you know, kids, oxycodone is very addictive. So don't use it if you don't have to. And if you have any extra that, you didn't need and you didn't use because you're smart, just send it to me and I will get rid of it for you.
I don't remember that I was present for that, no.
But the records reflect that Miss Klinker rated her pain as a 10 out of 10 worst pain ever.
Yes.
All right. What were the, it looks like, just following, chronologically here in the records, that's when she went for, after that is when she went for the CT scans.
Yes.
Now, I'm a lawyer, not a doctor, and so I don't know. Is there a difference between a CAT scan and a CT scan?
No, they're the same thing.
Okay. They eventually dropped the A out because
Yes.
it's inefficient or. So if you could just tell the court, what is a CT scan? What is it?
So it's a cross-sectional image. So it basically, like, if you think about an X-ray, you just get the views that you specifically line up the X-ray for. But with a CT scan, you can kind of see things in cross-section. So like if you think about something like laying down in front of you, you can see cut after cut after cut rather than just 1 to 2 views like you would in an X-ray.
And what's the advantage then of a CAT scan over sort of typical X-ray radiology?
So it depends. If you're looking at like a long bone or bony fracture, then there's no need for a CT scan. That would be picked up generally on an X-ray, not 100% of the time, but generally on an X-ray would be adequate. But if you're looking at bones of the face, if you're looking at a head bleed or head injury, the cervical spine, for example, there's a lot of small bones and just a lot of different like details that you would never be able to see on an X-ray. And then specifically for a CT scan of the head, you wouldn't be able to see any of the brain parenchyma, like the inside of the brain, for example. You'd just see the skull. That's it.
Okay, so in terms of imaging for the head, just because of the sort of shape of the head and the internal imaging, CT scan is preferable then, or
Yes.
the standard that you would
Yes,
use?
it would be the standard, yes.
Okay. And after Ms. Klinker returned from radiology from the CT scan, were you made aware of the results of the CT scan?
Yes, yes, I was made aware. They show up after our radiologist reads the results.
And what were the results of Ms. Klinker's CT scan?
So she had several facial fractures, and she had a small subarachnoid hemorrhage of the brain.
Okay. I want to sort of talk about those sort of things individually, if you can. In front of you is a little laser pointer right there.
Okay.
Yeah. So I'm just looking at this image that states exhibit number 2. I kind of want to walk through these fracture results from imaging, okay?
Okay.
So there is detailed that there is an acute right orbital floor fracture. So if I'm looking at this picture, where is the orbital floor, right orbital floor?
It's underneath, like the eyeball.
So the lower side fracture there.
Yeah, like in the bottom part here. That's, yeah, the orbital floor.
And what does it mean when it says it's an acute?
It just means that it's happened very recently.
Okay.
So.
It didn't indicate that it had evidence of healing, that it happened sometime in the past.
Correct.
Right? Okay.
Correct, yes.
It says that there was a lateral wall fracture. Where would the lateral wall be?
The outside area.
Okay, so outside of the eye, sort of more towards the ear.
Correct.
There is a medial wall fracture. Where's the medial wall?
That would be here,
So-
on the inside of the eyeball.
And then there was an indication of, I think, a protrusion into the sinus, if I understand that correct. I wasn't sure if that was a fracture or a displacement, or if it was just sort of a notice that she had some sort of nasal abnormality.
Was it the maxillary sinus, if I'm remembering correctly? Apologize.
Sorry, I had marks on my note.
Just because there's different sinuses, and I want to make sure
Okay.
that I'm
So
accurate.
was there some indication that she had injury to her sinus area, or maybe I misread that? So
you can tell me where the read is specifically from radiology, I can tell you
I'm on
exactly.
page 33.
33,
I was sort of
okay.
looking at the results.
It doesn't look like they've reported any sinus issues, but hemorrhage in the right base of the antrum.
Okay.
So
So
just
in
hemorrhage
addition-
around this.
I'm sorry. I didn't mean
Just
to-
hemorrhages around the side of the fracture is how I would interpret that. So.
Okay. Now, in addition to the observed fractures on the skull bone or the orbital area around, was there also a result? I think you had said that there was a subarachnoid hemorrhage.
Yes.
And can you explain for the judge what is a subarachnoid hemorrhage?
So there's different types of brain hemorrhages resulting
Bleeding in her brain along with the 3 skull fractures.
from trauma, and they're named based on how, like where they are in relationship to the areas that cover the brain. So a subarachnoid hemorrhage would be beneath the arachnoid matter, which is like one of the coverings of the brain. So trying to describe this, the brain has like multiple layers of covering. There's the dura, the arachnoid, the pia,
Like an
and so
onion.
like when there's an injury, it's classified or named based on where it is in relationship to the coverings. So.
Okay. So you have the bone, the skull, you got the dura, you got the arachnoid. Am I getting these in layers correctly?
Yes.
Before you get to the brain matter beneath.
Correct.
So when you say that there is a subarachnoid hemorrhage, that means there is, first of all, what's a hemorrhage then?
So just blood inside of the brain that's in the parenchyma or in an area where it's not supposed to be.
Okay, so you have some injury that's inside the skull area, a bleed that's
Correct.
in that layer that's below the arachnoid.
Correct.
Okay. And I know you said you've got some, obviously, history doing trauma. You also have neurocritical care. What are the types?
Could you imagine being married to, all right, you know how if you are not a nurse, you go home after a long day of work, maybe some things happened, you start to tell your husband about your day, and he's like, uh-huh, mm-hmm, uh-huh, and you know he's not listening, but sometimes he can pretend by repeating certain words back. Oh yeah, the coffee cup. Oh, that report sucks. But if you're a nurse and you go home and you're using all these words, all these big medical words, that your husband's had no chance at all, none.
Of mechanisms of injury that can cause a subarachnoid hemorrhage?
So subarachnoid hemorrhages are either caused by trauma or they can be caused by a ruptured aneurysm. And they look different. A traumatic injury is going to look very different on the CT scan than a ruptured aneurysm would. I guess I'll put like the ruptured aneurysm appearance aside because it's not the situation
That was not
here.
what occurred here.
Correct. That's not what occurred here. But the mechanism of injury can be pretty broad. So basically anything that's a blunt force to the head, whether it's an assault, a car accident, injury, and then certain populations are at higher risk of different types of brain hemorrhages. For example, patients who are on blood thinners or anticoagulated are going to be at higher risk. So.
And just sort of to just touch on that, I mean, during the assessment process,